I am back. Can you hear me?
Yes, sir.
Yes, sir.
Miss Jackson, no is there. Can you hear me? Still having connection problems. All right. All right, let's continue with the patient assessment for the airway patient. Assessment of respiration. Even though the patient may be ventilating appropriately, respiration may be compromised. Level of consciousness and skin color are excellent indicators of respiration. Also consider oxygenation, and this is where your pulse oximetry is considered, right? So once you have it available and you're assessing the patient's respiration, it's good to get a pulse ox reading on your patient. And usually a reading below 90 will require high flow. If it's above 90, you can start with low flow oxygenation of your patient. But once they start to go below 90%, they will desaturate very quickly. Now, if you're using a pulse oximetry, do not treat the pulse ox. You're treating the patient, right? A patient can have a good pulse ox reading and they're poorly oxygenated. Always treat your patient, not equipment, not the part. Focus on the entire patient. Now, opening the airway. Now, upper airway and lower airway. That's what the respiratory system consists of. So you need to know to manage the upper and lower airway. And the upper airway is simple. It's either the patient's upper airway is going to be patent or open, or it is partially closed, or it is completely obstructed, right? And if it's patent or open, that's what we want. So if it's patent and open, the next thing that we need to determine is if the patient has good air exchange. So if upper airway is fine, you move to lower airway. If the patient has a partial obstruction, then we need to determine if this partial obstruction is affecting air exchange. Is the air exchange good or is the air exchange bad? So if the patient has a partial obstruction at the upper airway and it is good, all we have to do is support that. We just need to support the partial obstruction. Once it's good, just monitor the patient. If the partial obstruction is affecting air exchange, then you have to treat it as a complete obstruction. And then you have the complete obstruction. And the first thing that we think about with complete obstruction of the airway in an unresponsive patient is the tongue, right? The tongue is the first thing we're going to think about. And to remove the tongue from the air passage, it is manual. So this is the steps. Manually position the airway, check to see that it's clear, assess, maintain. That is your approach. Manually position the airway, ensure that it is clear of fluids, assess, maintain. That's it. Now, opening the airway. Emergency medical care begins with ensuring an open airway. Rapidly assess whether an unconscious patient has an open airway and is breathing adequately. Position the patient correctly. Supine position is most effective, right? So the best position to put your patient in when you're going to assess and manage the airway is supine position. So if you find them on them side, you probably have to put them in a supine position. If you find them prone, you may have to put them in a supine position if they are unresponsive. If they are slumped in a bathroom snoring, you may have to put them in a supine position, right? That's the best position. Unconscious patients should be moved as a unit. Most common airway obstruction is the tongue. We know this because we are bright people at this stage. We're very bright. Other causes of airway obstruction: dentures, false teeth, blood, vomitus, mucus, food, other foreign objects, right? Now, once a patient has fluid in the ear passage, right? Once the patient's head can move without any complication, you always turn the head to the side and allow gravity to assist you. So you turn the head to the side, let gravity help you get that fluid out of the ear passage. If all light don't come out, then you suction, right? There are situations where that might not be possible, right? And you will have to suction with the head neutral. But once you can turn the head to the side, turn it to the side. If it's a suspected spinal injury patient, you turn the patient as a unit. Now, the techniques that you need to be familiar with for opening the airway is your head tilt chin lift and your jaw thrust maneuver and your controlled head tilt chin lift, right? So head tilt chin lift is for a patient with no suspected spinal injury, right? We will use the head tilt chin lift method. For the jaw thrust is indicated if we suspect spinal injury. So we are moving the jaw and the tongue out of the ear passage without manipulating the neck, without causing any severe movement in the neck or extension or flexion in the neck, right? Now, if the jaw thrust is not sufficient, then that's where you will use a controlled head tilt chin lift, which is basically doing the head tilt chin lift slowly until there is enough room to pass an airway adjunct. Once the airway has been opened, look at the chest and observe for movement. That is very important, you know. So if the tongue is in the ear passage, it makes no sense you assess the patient's breathing if you have not moved the tongue out of the airway. So you must position the airway first, then assess breathing. Position the airway first, then assess breathing once the patient is unresponsive. Even if the airway is open, the mouth may be closed. You can use a cross finger technique. Not going to go too much into this because that's practical. Right? And that's a slide showing the technique. So you're pushing the mandible upward and then keep it out. So it's up and then forward with your thumb. Right? You're using your middle finger and ring fingers to manipulate the mandible. Push it up and use the thumb to keep the chin out. So use the thumb to push the mandible out. Once it's up, push out. All right. Now, suctioning. If there is fluid in the ear passage, we may be required to clear that secretion. And you have different suctioning devices. You have your portable, you have your handheld suction, and you have the fixed mounted suction, which is on the unit. Now, we don't really use portable handheld suction anymore in the field because they don't really do that much. In my experience with using it, didn't do a lot for the patient, right? we tend to have the hand operated suction. That's the one that we move with, and the fixed unit. Right now, when there is a lot of secretions in the ear passage, once you suspect that there is secretions, and you can turn the patient's head to the side or turn the patient as a unit, do so, right? If there are chunks, because sometimes the vomit might have chunks in it, you may have to use your glove finger to clear that, right? You can't suction chunks. So while you are clearing, your partner get the suction catheter ready. Once the suction catheter is ready, then you measure and you suction the patient's airway. Now, if there is a large amount of secretions in the ear passage, you will use your rigid or Yanker tip suction catheter. If there's minimal secretion or the patient has spasm in the muscles in the upper jaw or lower jaw where you cannot open the airway that much, then it's better to use a flexible or French tip catheter. And if they have secretions coming out of the nose, flexible catheter would be appropriate. A portable or fixed unit should have a wide bore, thick wall, non-kinking tubing, plastic, rigid pharyngeal suction tips, non-rigid plastic catheters, a non-breakable disposable collection bottle, and water supply for rinsing the tips. Techniques for suctioning. The first thing, you need to be familiar with your suction unit. So you have to turn it on, and you have the new type suction units. Once you turn it on, it quickly goes up to 300 millimeters of mercury. So you want a suction pressure of approximately 300 millimeters of mercury. The old type suction devices, you may have to kink the tubing to build that pressure up. Once you have the desired pressure, then you need to test that suction, right, to see if it's working properly. Once you test the suction to see if it's working properly, then you measure and you suction. And when you're suctioning, you insert the suction catheter into the patient's ear passage, into the fluid. Once into the fluid, you create suction while coming out of the patient's ear passage. You don't suction going in, you suction coming out. So it's circular motion out, side to side. Never suction the mouth or nose for more than 15 seconds at one time for an adult, 10 seconds for children, 5 seconds for infants. So it's 15, 10, 5. No more than 15 seconds for an adult, 10 for a child, 5 for an infant. 15, 10, 5. If you suction the patient too long, you can cause hypoxia. And you can dry out the mucous membranes. And you can also stimulate the vagus nerve, which controls the heart rate, and that can slow down the patient's heart. When patients have secretions or vomiters that cannot be suctioned easily, remove the catheter from the patient's mouth, log roll the patient to the side. And when you turn in a patient, always turn the patient in a direction that you can see what is coming out of the patient's mouth. Clear the mouth carefully with a glove finger. That's for the chunks. If the patient produces frothy secretions, as quickly as you can suction them, suction the airway for 15 seconds, less in an infant and children, and you ventilate for 2 minutes. So you would suction, ventilate, suction, ventilate. That's when they have a lot of secretions constantly coming out. And you will continue to alternate that pattern until you reach the hospital. So there are some patients where you will not be able to move from airway to do anything else, right? Because the airway is critically compromised. Now, your basic airway adjuncts. So we looked at positioning, head tilt chin lift, medical patient, jaw thrust maneuver, trauma patient. If there is fluid in the airway, turn the head to the side or turn the patient as a unit. Clear chunks if you need to. Choose the most appropriate suction catheter. Rigid, large amount of secretion. Flexible, minimal secretion or secretions coming from the nose. Suction pressure should be at least 300 millimeters of mercury. Measure your suction catheter for depth. Once you insert inside the ear passage, you will suction coming out. You don't suction going in. Now, once you have cleared the airway, you need to assess. Now that I have cleared the airway, is air moving from the upper airway to the lower airway? Do I see chest rise? Right? Now, if you do not see chest rise, we have a problem. Right? So if you clear the upper airway and you look, listen, and feel, and you don't see chest rise, your patient has a ventilation problem. Your patient have a ventilation problem. Now, if you're manually maintaining the airway, you can manually maintain the airway and fix a ventilation problem. You need your hands, right? You're gonna need your hands. So we have airway adjuncts to assist us, right? And that's where airway adjuncts come into play. So basic airway adjuncts prevent obstruction by the tongue and allow for passage of air and oxygen into the lungs. I have the oropharyngeal airway, which goes into the mouth. It keeps the tongue from blocking the upper airway, and it makes it easier for suctioning the oropharynx if necessary, right? So you can suction to the side of that device. It is indicated, so the OPA or oropharyngeal airway is indicated when you have a patient that is unresponsive with no reflex, gag reflex meaning vomiting reflex, and a ventilation problem. I'm going to repeat that. So the OPA or oropharyngeal airway is indicated when you have a patient that is unresponsive, no gag reflex, and a ventilation problem. Right? So unresponsive patients without gag reflex and a ventilation issue. Apneic patients being ventilated with a bag valve mask, BVM. Contraindication. If the patient is conscious, do not use the OPA. If the patient has an intact gag reflex, they will gag on the airway, so you cannot use it in that patient. Then we have the nasopharyngeal airways. Indication. So this is a patient who might be unresponsive or semi-responsive or altered level of consciousness, but they have an intact gag reflex, but they're still having a ventilation problem, right? So nasopharyngeal airway is indicated in a patient that might be unresponsive or semi-responsive with a gag reflex, but they are still having a ventilation problem. So we still need to breathe for them, right? But we can't put anything in the mouth. So we have to put a device in the nose. That's a nasopharyngeal airway. Indication, semi-conscious or unconscious patients with an intact gag reflex, patient who will not tolerate an oropharyngeal airway. Contraindications, if the patient has a head injury with a suspected skull fracture, we do not use the NPA or nasopharyngeal airway. All right, recovery position, you are familiar with it. I think Miss Jackson had mentioned how when that particular position is indicated. Recovery position used to help maintain a clear airway in an unconscious patient who is not injured and is breathing on his or her own. Won't go into the skills aspect of that, not until you're in the classroom. All right, so that's the upper airway. We finished with the upper airway, right? So upper airway is position, clear, assess, maintain. Position, clear, assess, maintain. And if the airway is not open and the patient is unresponsive, the first thing you think about is the tongue. So we have to position. We will either use the head tilt chin lift for patients without suspected spinal injury, or we'll use the jaw thrust method for patient with suspected spinal injury, or we will use a controlled head tilt chin lift if the jaw thrust is not effective. Once we position the airway, we need to check to see if it is clear. Is there secretions or fluid or blood? If there is fluid and the patient head can turn to the side or the patient can turn as a unit, do that. Get your suction ready, right? Clear chunks if you have to. Use a rigid catheter if there is large amount of secretions. Use a flexible if there is minimal. Clear that ear passage using your suction. No longer than 15 seconds for an adult, 10 seconds for a child, 5 for an infant. Once you have cleared the ear passage, next would be assessing. Is ear moving from the upper airway to the lower airway? Can I see chest rise? If there is no chest rise, then you must create the chest rise. And to do that, you need your hands. So you will now have to use your airway adjuncts in conjunction with your bag valve mask device or a pocket mask, right, to provide positive pressure ventilation for the patient. The OPA goes into the patient's mouth. It is indicated if the patient is unresponsive, no gag reflex, poor chest rise. The NPA goes into the nose. It is indicated if the patient is semi-responsive with a gag reflex, poor chest rise. Once these devices are inserted, then your hands are now free to use your pocket mask or your BVM to breathe for the patient at the most appropriate rate. Now let's look at the supplemental oxygenation. Always give oxygen to patients who are hypoxic. Some tissues and organs need a constant supply of oxygen to function normally. Never withhold oxygen from a patient who might benefit from it. Right? And you assess the need for oxygen. So you will give it if it is needed. You don't give it if the patient don't require it. Supplemental oxygen equipment, become familiar with how oxygen is stored. Oxygen cylinders contain compressed gas, and that gas is under high pressure. Liquid oxygen becoming a more commonly used alternative. You're not going to see that much in field EMS, right? Safety consideration. Handle gas cylinders carefully. Make sure the correct pressure regulator is firmly attached before transport. And how the regulators are designed, it's very difficult to attach the wrong regulator to an oxygen cylinder because it uses a pin indexing system, right? So there are pins on the regulator that can only line up on the cylinder. A puncture hole in a tank can turn into a deadly missile. Secure cylinders when stored on the ambulance and when in use during transport. Right? So it uses a pin indexing system. It prevents such mistakes as oxygen regulator being accidentally connected to a carbon dioxide cylinder. Every cylinder of a specific gas type has a given pattern and a given number of pins, right? So and this is the smaller cylinders. The larger one uses the American indexing system, right? So you have to line up the pins with the regulator. Now, the pressure inside of the cylinder when it's filled is 2000 psi. We cannot give a patient 2000 psi of oxygen. Their lungs cannot manage that. So what the pressure regulator does is reduce the 2000 psi to 40 to 70 psi, and then we can adjust a flow rate that is appropriate for the patient based on the device that we are using, whether it's a high flow device or a low flow device. So you have flow meters, usually permanently attached to the pressure regulators or emergency medical equipment. So you have the pressure compensated flow meter. You will see that one more in the hospital. So that's the one that when they turn it on, you see a ball floating upwards, right? That's the one in the hospital. Then you have the burden gauge flow meter, which is the one that we use in the field in EMS. Now, hazards of supplemental oxygen. It supports combustion, right? So if a fire can get oxygen, it will certainly get worse, right? It supports combustion, and then you have what is called oxygen toxicity, right? So we don't want to over oxygenate the patient because that can create free radicals. In other words, you're putting oxygen molecules in the blood that have no cell to bind to, right? And when we have free radicals moving around in the body, they will damage cells that already have oxygen on them, right? So too much oxygen can be bad for a patient. Also, if the patient is having a heart attack or a stroke and you give them too much oxygen, it can cause their blood vessels, the blood vessel that supply the brain and the heart, to vasoconstrict, right? And that's not good for a damaged heart or a damaged brain. So again, we will give oxygen based on the patient's presentation. So if it's not needed, we don't give it, right? It is a medication. So there are indications and contraindications. Now, combustion. Oxygen does not burn or explode, but does speed up the combustion process. Keep any sources of fire away. Make sure the area is adequately ventilated. Never leave an oxygen cylinder standing unattended, right? And you shouldn't have that type of cylinder in the field. You should have a small cylinder that can go on your stretcher. You don't want a cylinder standing up in the field, because no matter what you tell people, say, yo, don't stand up so close to that cylinder there over there. So them not gonna listen. Somebody's not going to listen and bounce that cylinder over. And you don't want that stem to crack. That's 2000 psi if it is filled with oxygen. Oxygen toxicity. Not all patients need high concentrations of oxygen. Oxygen can have detrimental effects in patients with certain illnesses. COPD, they rely on the hypoxic drive, so they function on low oxygen, right? When pulse oximetry is available, tailor oxygen therapy based on pulse ox. And I mentioned to you that once you have a pulse ox that is above 90 but less than 94, low flow oxygen is fine, right? If it starts to drop below 90%, then you definitely need to think about high flow. If the patient is showing obvious signs of hypoxia, you need to give high flow. Now, oxygen delivery equipment. So in EMS, we use the non-rebreathing mask, bag valve mask, and nasal cannula. The non-rebreathing mask and the bag valve mask are high flow devices. Nasal cannula would be low flow supplemental oxygen devices, right? So the non-rebreather is the preferred way to give oxygen in the pre-hospital setting to patients who are breathing adequately but are suspected of having hypoxia. So if your patient need high flow, non-rebreathing mask is the ideal device, or you can use a partial non-rebreathing mask, or partial rebreather I should say. So you have non-rebreather, I have partial rebreather. A non-rebreather mask can give you a flow rate of between 10, 12 to 15 liters per minute. Anything below that would not inflate the bag on the non-rebreather mask. So it is 10, 12, or 15 liters per minute. It's high flow. So the patient can get up to 90% of oxygenation. Right? So non-rebreather mask, make sure the reservoir bag is full before placing the mask on the patient. Now remember what I said, anything below 10 will not effectively inflate that bag. So 10, 12, 15 liters per minute. Adjust the flow rate so the bag does not collapse when the patient inhales. When oxygen therapy is discontinued, remove the mask. Make sure to remember that part. So if you have a non-rebreather on a patient, do not turn off the oxygen with the mask on the patient. Take the mask off first, then turn off the oxygen. Why would I need to do that if it's a non-rebreather? Who can answer that question? Miss Jackson, still having connection problem? Miss Nesbeth, why do I need to take the non-rebreather off before turning off the oxygen?
Because no oxygen will be coming in because that's the only, so the machine will be the only source of oxygen the patient gets. None will be
Right,
coming in from the air.
right, good. Right, so it's called a non-rebreather. It means the patient cannot rebreathe outside oxygen. Right, they can only breathe the oxygen that is coming from the tank. So if you turn off the oxygen, it will completely form a seal on the patient's face, can suffocate, right? So remove the device first, turn off the oxygen after. Okay, good. Now, nasal cannula, low flow device, right? It goes into the nostril, and you're looking at 1 to 6 liters per minute, right? 1 to 6 liters per minute. And that will give you about 24 to 44%. Now, for test purposes, the range is 1 to 6 liters, right? So that's the textbook answer to the question. When you're in the field and you're using a nasal cannula, do not go beyond 3 to 4 liters in the field. If you have to go beyond 3 to 4 liters in the field, might as well you put the patient on high flow, right? So anything beyond 3 to 4 liters, it's going to burn. It's going to irritate the patient's mucous membrane, right? Now, if you have to give a patient oxygen therapy over an extended period of time, then you need to use a humidifier, right? Will moisten the oxygen. Once you have to give long-term oxygen therapy, ensure that it is humidified. So again, if it, the textbook answer to the question, 1 to 6 liters per minute, that's a range. As an EMS provider in the field, do not go beyond 3 to 4 liters. If you have to go beyond that, might as well use a high flow device. If you have to give the patient oxygen therapy over an extended period of time, sorry, ensure that the oxygen is humidified, right? And make sure that the humidifier is clean, right? Now keep it on the oxygen cylinder for days or weeks or months. That's not good for the patient, right? So a humidifier should be changed between each patient, or on each shift you need to clean the humidifier. All right, now when you anticipate a long transport time, consider using humidification, right? And that's a little um, container device that is attached to the regulator, and it has water inside of it, sterile water, right? Don't don't fill the humidifier up to maximum, because you will start to get water into the line. Keep it at minimum, right? Now, limited use in pre-hospital setting. What does that mean? It means when we come off our unit and go to the patient and assess the patient, and we're providing oxygen therapy, we do not use the humidifier at that point, because if we have the humidifier on the cylinder at that point, it has to stay upright. So we use dry oxygen in the field as soon as the patient gets into your ambulance and you need to give them extended O2 therapy, then you can use the humidifier at that point. And you have disposable humidifiers in the States. You have some that are reusable, right? All are coming. Always try to give high flow oxygen through a non-rebreather. Go ahead, Miss Dennis. Go
How
ahead.
much time do you extended period for the dry oxygen?
If you're going over um, 30 minutes, or the
Okay.
interaction that EMS providers have with the patient will not go beyond 20 minutes, right? In the hospital, you'll definitely have patients on oxygen over 30 minutes. Those patients require humidification. Now, outside of that, if you have a patient with any type of infection that is affecting their respiratory tract, or they have airway burns, you need to use the humidifier early for those patients, right? And as I say, if you're going to keep the humidifier on the cylinder, please, for God's sakes, clean it. I have seen quite a few humidifiers that I am terrified for those patients in the hospital setting. Dirty, right? So make sure it's clean, as you can have a patient with pneumonia in a couple days. All right, now partial rebreathing mask. The partial or non, sorry, the partial rebreather is similar to the non-rebreather. The difference is the patient is able to take in some amount of air from the atmosphere, as well as oxygen from the tank, right? So they are breathing air from the atmosphere and oxygen from the tank based on the flutter valve. It is a high flow device, just like the non-rebreather. So which patient would I consider using a partial rebreather for, right? Now, one situation in which I will use a partial rebreathing mask is if I have multiple patients that require high flow oxygen, right? So if I have multiple patients that need high flow, it is better to use a partial rebreathing mask. And with a partial rebreathing mask, you're looking at 6, 8 to 10 liters per minute. So it's 6, 8, or 10 liters per minute. So if I have multiple patients in which I cannot monitor them constantly, I would use a partial rebreathing mask. So I wouldn't have to worry about the mask suffocating the patient if the oxygen runs out. Now, the other situation in which you can use a partial rebreathing mask is if the patient is hyperventilating, right? So in the hospital setting, a patient might be having a panic attack. That's what we mean when we say the patient is having hyperventilation syndrome, right? So they're breathing too fast, they're breathing off the CO2 in their body, and the blood is becoming too alkaline, which can cause abnormal contractions from caused by electrolytes shifting from their normal position. Now, what you will see in the hospital setting is you'll see them give the patient a paper bag to breathe in and out. So you want them to rebreathe the CO2, right? Now, in the pre-hospital setting, we do not do that. We don't give patients paper bags, right? And it doesn't mean that the paper bag does not work. It does work, but it's not a management that you will see pre-hospital providers do. And the reason is simple. A patient can be presenting as if they're having a panic attack and hyperventilating, but they are actually compensating for a metabolic acidotic state, right? Now, for instance, the diabetic patient who has the Cosmal respiration, that patient is in metabolic acidosis. So their pH is going down because of a metabolic problem, right? That's because the body can't get the sugar that it needs. And the body compensate for that using respiratory alkalosis, which looks like hyperventilation. And what they're doing when they're having respiratory alkalosis, which is rapid deep breathing, is they are breaking up that acid into carbon dioxide and water. Now, what would happen if I give that patient a paper bag? Who can tell me? Which bright spark can tell me? What would happen if I give that patient a paper bag? Yes, Mr. Jennings.
Well, if you give the patient a paper bag, they would be re-inhaling the CO2 that they're exhaling, and then that re-inhalation will then increase the concentration of CO2 in the lungs and in the body. So then that would further increase their metabolic acidosis.
Quite so. And then eventually, you will have a patient that is unresponsive and not breathing, right? So what we do in EMS is we will use a partial rebreather. The patient will need oxygen, but the patient need to breathe off that CO2, right? And regardless of the use of the partial rebreather, if a patient is having a panic attack or hyperventilation syndrome, you have to calm them down before you put the mask on them face, right? So don't just put the mask on them face and say, breathe, man, breathe, right? You're gonna have to have a conversation, right? Hello, sir, mom, listen, you're breathing too fast, right? You're gonna have to control your breathing. I have some oxygen here for you, but I can't give you the oxygen yet. You need to slow that breathing down. We're gonna do it together, right? So I want you to take a deep breath and you're gonna exhale slowly on my count. No, no man, they can't do it. Yes, you can, man. Both of we are gonna do it. Deep breath in. 5, 4, nice. You let it go too soon. Try again. So you calm the patient down. Have a conversation with the patient. Then you give them the oxygen, right? Don't just fling the oxygen upon them and say, breathe. I need you to breathe. Must have a conversation. All right. Then you have the Venturi mask. Now, in my 19 years of EMS, I have only seen this mask in a classroom. I've never seen it on a unit, right? I've never seen it on a unit. Now, what the Venturi mask is It is a mask, in simple terms, that you can start from low concentration and gradually go up to high concentration, right? So you can start low and gradually go up to high concentration. It would be the ideal mask for a COPD patient. Now, if we don't have a Venturi mask, we can simply use a nasal cannula for a COPD patient, right? But that's a Venturi mask, right? So medium flow device that deliver 24 to 40% oxygen, useful in long-term management of physiologically stable patients, right? Then you have your tracheostomy mask. This is a patient who has a tracheostomy, which is an opening in that membrane, right? Cricothyroid membrane. So they have a tracheostomy. You have special masks for that. Tracheostomy masks cover the tracheostomy hole and have a strap that goes around the neck. May not be available in an emergency setting. Improvise by using a face mask instead. Placed at the tracheostomy opening. Humidification, I've already talked about this one. Some EMS systems provide humidified oxygen during extended transport. Many EMS systems do not use humidified oxygen in the pre-hospital setting. However, as I said before, if you have a patient with a respiratory tract infection or airway burns, they will benefit from early humidification, right? For certain conditions such as croup. We're going to talk about that later on in the course when we do pediatric emergencies. Dry oxygen is not considered harm for short-term use. Now, assisted and artificial ventilation. Whether you use the term assisted or artificial ventilation, it means that you're providing positive pressure ventilation for the patient, right? So regardless of whether you see the term assisted or artificial ventilation, you are providing positive pressure ventilation for the patient. Now, probably the most important skill in EMS at any level. It is a skill that you will have to master. I didn't say do it to pass, I say you will have to master this skill, right? It must become second nature to you. Absolutely second nature. So basic airway and ventilation techniques are extremely effective. Follow standard precaution as needed when managing a patient's airway. Now, the difference between artificial ventilation and assisted ventilation is you provide artificial ventilation using your BVM or pocket mask for a patient that has no ventilation, right? So you provide artificial ventilation for a patient that has no ventilation. That's why it's called artificial ventilation. You are creating the ventilation. In other words, the patient chest now move. So you need to move it. And if you are moving the chest for the patient, that's artificial ventilation. Assisted ventilation is given to the patient that is ventilating. So that patient is ventilating, but it is not adequate. So that patient has poor chest rise, right? The chest barely moving, the LOC is compromised. So you are going to assist that patient's ventilation. You're assisting the ventilation because it's not sufficient. Assisting ventilation in respiratory distress or failure. Intervene quickly to prevent further deterioration. Two treatment options. So you have assisted ventilation and you have CPAP, continuous positive airway pressure. And CPAP is when they have fluid. So if they have fluid in the lungs, right, and the blood pressure is not low and they don't have any chest injuries, you can use a CPAP device. Now, signs and symptoms of inadequate ventilation: altered mental status, inadequate minute volume, excessive accessory muscle use, and fatigue. I don't get that fancy, right? So, what I will tell you is what you will use to determine if you need to breathe for your patient. Does the patient have an altered mental status? Does the breathing rate suggest that the patient is compensating or decompensating? Right? Can you see visible chest rise bilaterally? So if the patient LOC is compromised, breathing rate doesn't look like it's compensating. You can see severe muscle use and the breathing rate is coming down. And you see poor chest rise, then your patient need assisted or artificial ventilation, right? You're gonna have to breathe for that patient. Now, when assisting with a BVM, the best position for you to be at or be in is at the patient's head, right? Place the mask over the nose and mouth, squeeze the bag each time the patient breathes. This is for assisted ventilation. So if you're gonna breathe for a patient who is already breathing, but the ventilation is poor, you have to synchronize with their ventilation. In other words, you have to squeeze the BVM when that patient breathes in. You cannot squeeze the BVM when the patient is breathing out because you will force air into the stomach, right? So you need to synchronize with their breathing for at least 5 to 10 breaths, and then you regulate it at the normal breathing for an adult, which would be 1 breath every 5 to 6 seconds. If it's a child or infant, 1 breath every 3 to 5 seconds. Now, artificial ventilation. This is when your patient is in respiratory arrest. Arrest means stop. So them not breathe, right? Patient is in respiratory arrest, need immediate treatment to live, right? If a patient not breathing, you need to work fast. You need to work fast. Once a patient is not breathing, begin artificial ventilation immediately, right? If you are the only person at the head and there is no one there to assist you with the BVM, start off with mouth to mask technique. It is more effective than one person BVM. Now, over time, if you see a lot of emergencies in the field, your one person BVM technique will improve, right? You won't really understand what I'm saying until you come in the classroom and you have that BVM in your hand. That's where you're gonna realize how difficult it is, right? But if you have a pocket mask, that's a better method for a single rescuer, right? So if you don't have somebody to maintain a seal for 2-person BVM, a pocket mask is a better option. So it's mouth to mask, 1 or 2-person BVM, then manually triggered ventilation device. Now, you might not get the luxury of a manually triggered ventilation device in your system. All right, now normal ventilation versus positive pressure ventilation. I mentioned to you previously that when we breathe in and out normally, when we breathe in, it's negative pressure. When we breathe out, it is positive pressure. When you provide assisted or artificial ventilation for a patient, you are providing positive pressure. So it goes against the normal physiology of breathing, right? So it has to be slower than the normal breathing rate, right? So if a adult normally breathes at, 12 to 20, it needs to be slower than that. Can't be the same rate. Now, if your ventilations are too forceful with the BVM, you will cut off venous return, right? So you can cut off the blood flow that is returning to the heart, right? And one of the ways you can check that if you have enough providers on scene is when you are bagging the patient, let somebody palpate the carotid pulse. If the pulse is disappearing when you're squeezing the bag, it means your ventilations are too fast and too forceful. It's cutting off the venous return. So the pulse should not disappear when you're bagging the patient, right? That's something to pay attention to. Now, with positive pressure ventilation, we will get increased intrathoracic pressure, which reduces blood pumped by the heart. We have cut off the venous return, right? So there will be a drop in venous return. If it is too much pressure, it cuts it off completely. More volume is required to have the same effects as normal breathing. Air is forced into the stomach, causing gastric distension. So if our BVM technique is poor, we're gonna get air into the stomach, and that's just gonna make your life, well, I can't say make your life difficult. It's not gonna be good for the patient, and you have a lot of work to do, right? So once you start to get air into the stomach, your job is gonna become very difficult to manage the upper airway, right? Now, whoever is in charge of the BVM, you need to pay attention to what you're doing, right? So I can be at the head bagging the patient and I am looking to my left and right and watching what other people doing and squeezing the bag. If I am doing that, I don't know how many squeezes giving me chest rise because I'm not paying attention to that, right? So you need to ensure that when you squeeze your BVM or you're using a pocket mask, you see chest rise. And guess what? If you squeeze that bag and you don't see chest rise, the ear went somewhere, right? And if you don't see chest rise, it don't mean say you must increase pressure. That's a bad practice. We squeeze the bag, there's no chest rise, we force it in at the patient. No, right? If you don't see chest rise, the ear went somewhere and it will take the path of least resistance. That's the stomach, right? Now, one of the most difficult, I don't like to tell stories when I'm doing lectures, but I have to tell you this one. One of the most difficult calls I had as a paramedic was because of EMT not doing using proper technique for the BVM. So we got a call to a nursing care facility, and this was in the States. When we got there, the patient was in cardiac arrest. There were firefighters on scene. They were doing CPR, and one of the firefighters was bagging the patient. Now, when my crew got there and I started to observe what the firefighter was doing, I realized he wasn't paying attention. So when he's squeezing the BVM, you can see the patient's cheek puffing out. The cheek is puffing out, so the airway wasn't properly positioned, right? So immediately I said to him, "Hey, let me take over what you're doing." Now, when I took over the airway from him and my partner started to set up my intubation equipment so that I could pass a tube into the patient's lungs. When I lift up the patient's lower jaw, I could not see the glottic opening. All I was seeing is mucus and blood, a whole heap of blood, a whole heap of mucus. Now, the time that I should be using to pass my tube, I had to use that time to clear secretions. I had to use that time to do aggressive suctioning. so that I could see the ear passage to pass the tube in. And all of that occurred because the EMT was using poor technique, right? So again, basic before advanced. If your basic care is not good, the advance won't make a difference. I eventually got a tube into the patient's lungs, but the patient didn't survive, right? The patient did not survive. While en route to the hospital, it started to get very difficult for me to squeeze the back, and a lot of blood and secretion started to come up. So it means that the patient had aspirate blood and mucus into the lungs, right? So I had to end up suctioning again en route to the hospital. The patient kept getting back a pulse and then went into cardiac arrest again. Pulse went. And the following day, I heard that she didn't survive, right? Now, would the basic technique being effective made a difference? I don't know at that point, but the patient certainly deserved that, right? Now, the point of the story is if you're in charge of Airway, make sure you're doing it properly, right? Make sure you're using proper technique, proper positioning, your timing is appropriate, right? It is one breath every 5 to 6 seconds for an adult. So it's squeeze, 2, 3, 4, 5. Squeeze, right? Very important. All right, now mouth to mouth. Sorry, mouth to mouth, mouth to mouth. Well, we don't really use mouth to mouth in the pre-hospital setting anymore, but if you have a family member, you may have to do that for a family member, right? Now, I have done mouth to mouth in the field one time. Well, I can't even say mouth to mouth. It's mouth to nose and mouth. I did it for a child because I couldn't find my face shield and the child stopped breathing on me, right? I didn't have time to search for a face shield, so I had to do mouth to nose and mouth for that particular patient. That patient survived, right? So that story has a good ending. Barrier device is routinely used in mouth-to-mouth ventilation. Mask with an oxygen inlet provides oxygen during mouth-to-mask ventilation. Now, signs of adequate ventilation. Patient's color will improve. You will see chest rise, right? If you don't see chest rise, adjust the position of the patient's head. If you do not see chest rise, reposition the patient's head, right? Reposition the patient's head. Do not squeeze the BVM harder or faster. Do not blow harder or faster into the pocket mask. You're going to push air into the stomach, right? Don't want that happening, or else it will be difficult to ventilate the patient later on. There should be no resistance. In other words, when you squeeze the BVM, you shouldn't feel a back pressure. You shouldn't feel a pressure pushing on the mask. If you feel a pressure when you squeeze the BVM, it means that the airway is not properly open. You hear and feel air escaping from the patient, right? If you can hear and feel air escaping, then your technique is good, right? No resistance, visible chest rise, color should improve. Bag valve, most common method used to ventilate patients in the field, provides less tidal volume than mouth-to-mask ventilation. An experienced EMT can provide adequate tidal volume, and it is a device that it will take you some time to get comfortable with. You won't understand what I'm talking about until you have the device in your hand. If you have difficulty ventilating with a BVM, switch to another method, and that method would be either two-person BVM or pocket mask, and the pocket mask would be more effective. The volume of oxygen is based on observing chest rise and fall. Whenever possible, work with partner to provide BVM ventilation. Gastric distension. This is what we need to avoid, right? Gastric distension occurs when artificial ventilation fills the stomach with air. Most commonly affects children. It can happen in your adult patient, right? Can see it in adults. Most likely to occur when you ventilate the patient too forcefully or too rapidly. May also occur when the airway is obstructed. To prevent or alleviate this tension, ensure the patient's airway is appropriately positioned. Ventilate at the appropriate rate. Ventilate with the appropriate volume. If the stomach appears distended, recheck, reposition the head, and perform rescue breathing. Passive ventilation is becoming very popular, right? Expansion and contraction create a pump for air movement, and this is something that we will see in the future in CPR. So what it is during CPR, you put a oropharyngeal airway adjunct in the patient's airway. You put on a non-rebreather mask with high flow oxygen, and you open the airway. And while your partner is doing chest compression, the negative pressure that is created from the chest compression will pull the supplemental oxygen into the lungs. So you're eliminating positive pressure, which puts the patient at risk for air getting in the stomach. It is becoming quite popular in the pre-hospital setting. So a couple of years from now, this might be how we perform CPR in the field. Now, ventilation devices, you're not going to see that much in your system. I won't mention a lot on ventilation devices, but all it is a machine that is creating the ventilation for the patient, right? Based on the settings that you put on the machine. And you have some machines that are manually triggered, meaning you have to press a button after you put in the settings and it create the ventilation. And you have some that are automatic. You just put in the settings and it automatically ventilates the patient. Then you have your CPAP. I mentioned this earlier. Um, will be indicated for patients with fluid in the lungs. It used to be it's used by patients that have trouble sleep or sleep apnea, which they're basically stop breathing. They stop breathing when they're sleeping, right? So they have to sleep with a machine. And what it does is it creates a pressure inside of the lungs to keep the alveoli open so that gas exchange can occur. Now, it is starting to become quite popular in field EMS, especially with patients with fluid in the lungs. Right? So it will help to push that fluid out of the alveoli. So it increases pressure in the lungs, it opens collapsed alveoli, it pushes more oxygen across the alveolar membrane, forces interstitial fluid back into the circulation. Therapy is delivered through a face mask held to the head with a strapping system. Use caution with patients with potentially low blood pressure. Indication: patient must be alert and able to follow command. They must be in moderate or severe respiratory distress. In other words, if they have poor chest rise with decreased level of consciousness, you cannot use the CPAP on them, right? Patient is breathing rapidly. The pulse ox reading is less than 90%. Contraindication: patient in respiratory arrest. Signs and symptoms of a pneumothorax or a collapsed lung. Chest trauma. Patient who has a tracheostomy. Active gastrointestinal bleeding or vomiting. Patient who is unable to follow verbal commands. Right? application, not going to go into that. No. Complications. Some patients may find CPAP claustrophobic, and we usually let the patient hold the mask on their face until they get comfortable with it. Then we put the strap over the head, right? Based on the pressure that is being created in the lungs, it can rupture the alveoli, right? Especially in patients with chronic lung disease. It can cause a drop in the patient's blood pressure because it's positive pressure, so it can decrease venous return. If the patient shows signs of deterioration, take off the CPAP, get ready to provide your positive pressure ventilation. All right, special consideration. Patients with stomas, opening in the cricothyroid membrane, or they have in a tracheostomy tube in the neck. It can be a partial tracheostomy or a complete. If it's partial, they can still move air through the nose and mouth. If it's complete, they cannot. Now, the most common call you will get for tracheostomy tubes or stomas is a mucus plug. So it clogged up with mucus and they need to clear it, right? I don't like those calls, but hey, we gotta do it, man. We gotta do it. Now, if you're going to suction the stoma or tracheostomy, it must be a sterile technique. So you have to have on sterile gloves. Once you have on these sterile gloves, your hands cannot pass your waist, right? And you will use a flexible catheter, and the catheter, it does not come out of the pocket until you're ready to use it. So it comes out of the pocket and goes into the opening, right? That's how we will suction. You don't want to exceed more than 10 seconds with that. All right. Now, neither the head tilt chin lift nor jaw thrust is required. If the patient has a tracheostomy tube, you can ventilate through that tube because it has a connection for the BVM. If the patient has a stoma but no tubes in place, use an infant or child mask with your BVM to make a seal over the stoma. All right, now foreign body airway obstruction, which is the last part of the airway chapter. This is really BLS, right? So you would follow BLS procedures. Not gonna go through this portion of the chapter because it's something that you will cover in your BLS course. What you need to remember with your foreign body airway obstruction, I've said it earlier, a patient can have a partial obstruction with good air exchange or a partial obstruction with poor air exchange, right? And sorry, you will simply follow the BLS protocol. Use your abdominal thrust if the patient is not unresponsive. When they go unresponsive, you will initiate CPR. The only difference is before you give breaths for the patient, you will check to see if there is something in the ear passage. And if you can reach it, you remove it, right? But you can go back and read that on your own. Not going to spend a lot of time on that. All right, now for your dental appliances, it's also very straightforward. If it is firmly in place and you can use your equipment effectively and get the results that you want, leave the dental appliances in place. If your technique is being affected because the dental appliance is not in firmly or too loose, then you may have to take it out in order to better manage the patient. And that's basically airway management in a nutshell. Now, with facial bleeding, airway problems can be particularly challenging in patients with serious facial bleeding. The blood supply to the face is very rich. Injuries can result in severe tissue swelling, bleeding into the airway, control bleeding with direct pressure, and suction as necessary. And remember, if it's a lot of secretions, rigid suction catheter. Minimal secretions, flexible, right? Or if fluid is coming from the nose, or you can't create enough space in the mouth, then flexible catheter would be a better option. And that should bring us to the end of this chapter. I'm not going forward. What's going on? Can you can everybody still see my slide? I think my computer just freezed up.
Still see it.
Yes, sir.
I'm not able to move forward. There is some drop connection on my end. Let me try again. Yeah, definitely. All right, I am back. You guys hearing me? Everybody hearing me?
Yes, sir.
Yes,
All right.
sir.
No echo, no echo. All right, so we're at the end of the chapter. Very interesting chapter, very important chapter. A chapter that I'm very passionate about because I've seen a lot of patients die in the hospital setting and also in the field because of poor airway management, right? And while I was going through paramedic school, it was drilled into my head that your airway management skills must be very, very efficient, right? It's very important to the patient's survival. Ensure that you spend as much time as possible with the chapter. If there's anything that you do not understand fully, feel free to ask me questions because I think I finished a bit early. Right? Maybe I was going a little too fast, but I am available for questions, right? All right. Miss Jackson, are you hearing me?
Yes, sir.
First question is yours. Go ahead. Who that
Please,
whisper? Who whispering?
I was wondering.
Okay. What is the
Yes, sir.
answer? B? B as in boy?
Yes, sir.
All right.
Yes,
Okay,
sir.
that's correct. That's correct. Rowan, number 2. Ron,
C, sir.
C as in cat.
Yes, sir.
A is the answer. Tidal volume, the volume of air that is moved in or out of the lungs in a single breath, is assessed by simply looking at the patient's chest rise and fall, right? Counting the patient's respiratory rate, that's rate. That's not tidal volume. All
Yes,
right.
sir.
Marvin, Mr. Jennings, number 3 is your question. The primary stimulus to breathe. Mr. Jennings, you still with us?
Sir, as they see.
C as in cat. That would be correct. Miss Nesbeth, number 4 is your question.
B, sir.
B as in boy.
Boy.
Signs of inadequate breathing in an adult include all of the following except. You're sticking to B?
It says adequate breathing. It's not inadequate, it says.
I'm just asking a question. You know? I'm
Oh,
just asking a question. Are you sticking to B? Yes or no?
yes, sir.
Okay. B is correct. Miss Johnson, number 5. This is a very good question. Remember, when you see the word you should, it is asking for the next step in a sequence. Number 5, Miss Johnson, you still with us?
Yes, sir.
What is your answer?
A, sir.
Excellent, right? So that's critical thinking. Patient start to gag, first thing you're gonna do, turn the head to the side, turn the patient as a unit. Once it is possible. Good. So learning. All right, Miss Dennis, number 6. Contraindicated. Good question. Comfort, Miss Dennis, comfort. Where are you?
D as in dog.
D as in dog. An unconscious patient who gags.
Sorry.
Okay, come again. Wheel and come again.
Contraindicated.
Contraindicated.
C.
C as in cat. C as in cat with your bad connection. Yes. I think she said C. Yes. Right, Miss Dennis? I think she said C. C would be correct. C is correct. Miss Jackson, very important. Well, good question. I won't say important. Good question. Number 7. Go ahead. Let's see if you people are learning.
C,
Go
sir.
ahead. C as in cat. That's what I heard.
Cat. Yes, sir.
That is what I heard, and that is correct. Rowan, number 8. Another good question. I am loving these questions. A patient is found unconscious after falling from a third floor window. His respirations are slow and irregular. You should. What would you do next? Your question, Rowan.
A, sir. A.
Place him in the recovery position. A patient that just fell from a third floor window. Recovery position. Isn't that a spinal injury patient?
Sir, yes. So,
You want to try again? Well,
yeah, man, I'm trying again. Hold, just give me 2 seconds.
might not have so much time, but go ahead.
All right, I'll go with D.
Why are you going with D?
All right, so his respirations are slower than the regular. So I believe when using the bag mask device to assist him with the breathing would be as a result of the fall that he had from such a height.
All right, yeah, overthink it, right? So, yeah, overthink. You're correct, but yeah, overthink the question, and this is for everybody. Don't overthink the question. When you're dealing with airway, is either you're addressing an upper airway problem or a lower airway problem, right? So when you look at your patient's presentation, you need to ask yourself, does this patient have an upper airway issue or a lower airway issue, right? So the patient is found unconscious. That means that there is an upper airway problem. Yes, because the tongue is in the airway. Because when a patient is unresponsive or unconscious, the tongue falls into the ear passage. So there is an upper airway problem. The patient is breathing slow and irregular. If the patient is breathing slow and irregular, that means this patient would have poor chest rise. So the patient automatically falls in the poor ventilation category. So there are 2 things that is needed for this patient. Airway positioning with an airway adjunct and positive pressure ventilation because of the poor chest rise, right? So the answer would be D, because the patient has a ventilation problem. So when you're assessing a patient's respiratory system, you want to know if the patient has a upper airway problem, a ventilation problem, an oxygenation problem, or a respiration problem, and you address it, right? Jennings, apneic patient. Number 9.
I would say D, sir.
D as in dog. I
Yes, sir.
presume that is correct. And Miss Nesbeth, the final question is yours. Interesting question. What do we do?
B, sir, reposition his head.
Excellent, right? We need to reposition. Good. All right, so to learn something today. Look like I'm gonna learn enough too. All right, so let's just quickly wrap up things. Yes, Ron.
Sir, is this one of the most complicated part of the course?
No.